Midgut volvulus is a surgical emergency, which is a result of non-rotation of the bowel, which eventually leads to bowel obstruction and the resultant ischemia of the proximal small bowel. In a normal fetus, the bowel protrudes outside of the abdominal cavity at the level of the umbilicus at about age 8 weeks and undergoes a number of rotations, eventually leading to a 270-degree rotation, at which point the bowel returns into the abdominal cavity, and it's usually stuck at 2 points at the level of the ligament of Treitz in the left upper quadrant, and the cecum is stuck in the right lower quadrant, kind of stretching out the mesentery, as you can see it on this last image. Midgut volvulus occurs when the bowel does not undergo this normal rotation, and that allows for a hypermobile mesentery, which allows the small bowel to twist around its mesenteric axis. These patients usually present acutely ill. About 75% of them presents within the first month of life, and about 90% present within the first year. These patients present with bilious emesis, signs of bowel obstruction, and eventually signs of bowel ischemia. The imaging study of choice for bilious emesis is an upper GI exam. On the first study here, you see a patient with malrotation without midgut volvulus at this time. Normally, you would like to see the duodenal C-loop cross the midline with the ligament of Treitz, the duodenal-jejunal junction, being on the left of the spine at the level of the pyloric channel. What you see here is contrast within the stomach, the duodenum, and the proximal jejunum, and the duodenum and jejunum are in the right upper quadrant. The duodenum did not cross the midline. So this patient has malrotation of the bowel, however, he is not acutely in midgut volvulus. On the second study, you can see the stomach distant with the contrast, and there is a corkscrew appearance of the proximal duodenum as it's twisting around its mesentery. This patient is acutely ill, so he has malrotation with midgut volvulus. This is a surgical emergency. These findings can be even better appreciated on a CT scan. However, that is not typically the first study of choice for the neonates. On CT scan, you can see a distended stomach and distended proximal duodenum, which then goes into the swirl in the central mesentery, where you can see the superior mesenteric vein and superior mesenteric artery swirling around, pulling bowel loops with them. And you may see also signs of bowel ischemia as well. As I mentioned it earlier with the pyloric stenosis study, normally you would like to see the superior mesenteric vein and superior mesenteric artery in normal configuration. The SMV is heading towards the liver, hence it should be on the right, while the SMA should be on the left. With midgut volvulus, you can see these vessels twisting around each other, and you may also appreciate the loops of small bowel pulled in, wrapped around the central mesentery.